Welcome, everyone. Thank you for your patience. We are ready to start now. We have lost one of our first speakers, so that's why we had a bit of a delay, but that's fine. We still have the amazing Suke here to talk to us about AI in healthcare to start off. Before I go any further, I just want to acknowledge the Turrbal and Yugara peoples, who are the traditional custodians of the land on which we meet today, and pay my respects to their elders past and present. And I extend that respect to the Aboriginal and Torres Strait Islander peoples here today, and obviously anyone online. So welcome to our Healthcare Forum. Thank you all for coming. I think we can all agree that it's a privilege to be here in person, even if we are all masked up. So on that note, given the current restrictions, we do want to make sure we have a COVID safe event. So we do need everyone to always be wearing masks. We do have networking after with food. When you are eating, you need to be seated because you will be allowed to take your mask off to eat, obviously. And the panelists will have their masks off to speak, to make sure it's accessible for everyone. But other than that, it's masks on, but it looks like everyone's happy with that. So thank you very much. So in case you don't know me, I'm the MedTech Program Manager for the AI Hub. So I'm very fortunate to be able to bring amazing people like you guys together here, and the incredible lineup of speakers we have will be really interesting. I think we're going to have quite a dynamic discussion today. So without further ado, I think we'll just dive into it. So first up, we have Suke, and we do actually have our panelists, so we will welcome him to the stage. So if you'd like to give a round of applause and welcome Dr. Suke and Dr. Dave Hansen as our first speakers. So while they're getting set up, I'll just give you a little intro in case you don't already know these people. So Dr. Suke is currently the CEO of the Queensland AI Hub. After leading cyber physical systems research for CSIRO's Data 61. Previously, she set up the world's first robotic vision research centre, leading the development of Australia's first robotics roadmap, the Robotics Australia Network and the Queensland Robotics Cluster. A graduate of the Australian Institute of Company Directors, Sue founded and chairs the board of Robotics Australia Group, and amongst others. And we also have Dr. Dave Hansen. So he is currently the CEO and Research Director of Australian eHealth Research Centre, CSIRO. Dave Hansen has extensive leadership experience in building innovation-based organisations that deliver information and communication technologies to the health and life sciences industries. David has a rare mix of skills and experience incorporating executive leadership, technical research, product and business development, and spanning the private and public sector. David is passionate about the use of information to improve outcomes across the health and life sciences industry, from biomedical research to the delivery of health services. David has held senior positions, leading technology research and development with the Lion Bioscience in Cambridge, UK, and the Australian eHealth Research Centre in CSIRO, Australia. Over the past 6 years, David has developed CSIRO's eHealth Research Program, first as eHealth Theme Leader and now as CEO of the Australian eHealth Research Centre. So welcome to both of you, both very much experts in this area that we can start us off on our topic today of AI for healthcare. So firstly, I'd like to hear from you both. What do we mean when we say AI in healthcare? Maybe starting with Sue, what do we mean when we're talking about AI in healthcare?
Well, that could lead to a whole afternoon worth of debate.
Yep.
The way I think about AI is just any situation where we use a computer or a machine to make a decision that we would otherwise make using a human. And in some cases, those decisions are just for support, and we still allow a human to be the person that makes the ultimate decision. But we're getting to the point now where we can rely on artificial intelligence to make decisions that make sense to us and that we are increasingly relying on. So very broadly, I mean, that's how I would define artificial intelligence, whether it's applied to healthcare or any other sector.
Thank you. And David?
No, so look, I think Sue hit a few nails on the head there. Obviously, I think the use of AI in healthcare is actually new. The application of AI in healthcare is one of the early applications of AI was trying to do something with X-rays or something like that. So it's been around for a long time. What we've seen over the last few years is just the sheer increase in data being captured electronically and with high quality, as well as compute power. And so that's enabling us to really reimagine how we're using data and compute with AI algorithms to really change how we deliver healthcare. So there's so much happening in this space at the moment. It's really exciting.
Yeah, fantastic. That's right. And maybe over to you, Sue. Where are we at with AI in healthcare in Queensland? I mean, is it already going on, or are we still developing it? If you could speak to that.
Yeah, I think we've seen a number of developments. At the Queensland AI Hub, we're constantly looking for examples of AI that is developed and commercialised here in Queensland. And one of the things that we are noticing is that many of the companies who have developed AI products are looking to supply into the healthcare space. Quite a few of those companies are commercialising research out of universities. So a couple of notable ones would be ResApp, that are commercialising an app on your smartphone that will diagnose respiratory illness based on the sound of your cough, which was based on some research done at the University of Queensland. Also at the University of Queensland is a device called Steppy, that is essentially a digital stethoscope that is being commercialised from that original research. There's another company on the Gold Coast called Cardia Mobile that's developed a sensing technology so that you can determine ECG without having to put sensors all over someone's chest. You can actually just do it on this device. They've sold more than 1 million of these devices across the world. I would say in terms of maturity though, we're very much, and I mean, this is not just true of Australia, it's true in the US too, we're not at the point that many of these technologies are being approved as medical devices. They tend to only be approved as diagnostic support tools. And so I think the real step change will be when we get to the point that these technologies are able to be applied more broadly. But I think I often say that COVID's never been a better time to be in the AI or robotics space, because it really has highlighted the need that Australia has always had in terms of being able to deliver remote services to people in healthcare. And I think that's something that Australia has always led the way in terms of telehealth, but it has just upped the ante in terms of the need for us to actually be often having physical devices that can be used by people out in remote communities to be able to allow them to get similar services to what you might expect in the city.
Yeah, fantastic. So it sounds like we are already developing some pretty cool technologies using AI for healthcare in Queensland, which is very exciting. And then David, obviously data is really the foundation of a lot of these AI tools. What kind of data are we speaking about when we speak about data for AI?
Well, I think you said it there, which is almost any sort of data which is capturing the healthcare system. And I'll add on to some of these comments there. In Queensland, we're really lucky, actually, in some ways, that we have such a consolidated approach to data in our healthcare system. And I see Claire there, so I imagine she'll be talking about this a bit later. But we do have a single electronic medical record in Queensland for all our, for everyone who lives here. And that gives us some real power in the data that's being collected. So that's the clinical data which is being collected, but in our hospitals. That as well, that's clinical data which clinician centre, but there's data coming off devices which are connected to patients into the EMR, which includes things like pulse oximeters and blood pressure. All that sort of information goes into our medical records. So it's a really rich data source. You can imagine what you can do with that. But then, of course, there's all sort of imaging data when you have an X-ray or a CT scan or an MRI, and that sort of information also lends itself to AI. And of course, we're moving into the genomics era where people will be treated taking into account their genome sequence. And that's moving something which has happened in the research world for a long time, the sequencing of humans for research studies into the clinical world. And so over the next few years, we'll see the amount of sequencing going on for research probably decrease, while the amount of sequencing going on for clinical purposes really explodes. And so that's a whole other set of data which can be added together, and think about machine learning, which might combine genomics with clinical data, and even look images, and you can really start to think about personalised medicine. At which point I've totally forgotten the question on that.
No, I think you answered it, which basically is all data, any data, and probably things that people don't always think of as health data can be used. So no, excellent answer.
And look, I think that's in the hospital sector. I want to mention that, of course, GPs collect data, but we ourselves do collect more and more data on our phones in particular, whether that's our exercise data or, you know, Apple Watch now, and some been starting to use that little ECG thing, just for fun more or less. But, you know, increasingly, yeah, we're going to send up to our doctors, go, oh, look at this data, and Claire's going to go, oh, no. You know, this is you know, where I think AI has got a lot to add, and a bit of fun as well. And while and I think AI is going to, one more thing, sorry, AI is going to be a wide range of technologies, whether it's something, a commercial product, and Sue mentioned some of those which end up getting regulated. But you know, the doctors tend to be pretty clever people, and the ones I've met are, and you know, the AI tools which are coming out now are incredibly easy to build your own tools. And so, you know, we're going to start to see a whole range of maturities and decision aids which aren't, you know, making a decision, but are helping doctors and clinicians. So this is a really exciting time.
No, fantastic. And then just one more question. If in one sentence you can let us know, what do you envision for the future of AI in healthcare? Yeah, sure. And we'll just get you to speak from this mic because I think some people are having trouble hearing. Apologies for that.
Okay, I'll go first. The future of AI in healthcare? So,
yeah, in one sentence.
Oh, one sentence. I think I said it, which is that we're just, it's going to be, I know it's really serious, I know, and there's a lot of opportunities, but we should be looking at it as fun. What can we do with this data to really make a difference for our healthcare system, for our patients, and more importantly, for a sustainable healthcare system? You know, a lot in the news at the moment is what's going to happen to our healthcare system, which is already overstretched when all of a sudden we have 1,000 cases of COVID every week, which unfortunately is going to happen at some point, hopefully in more than 6 weeks after my son finishes his grade 12 exams. But, you know, I think there's the opportunity for lots of fun with AI in healthcare, as well as really tackling some great challenges.
Thank you. And Sue?
Yeah, I agree with David. I mean, AI is an opportunity for us to be able to achieve things that, you know, before we've had, you know, only had the ambition but haven't been able to achieve. And I think that it is making personalised medicine finally within our reach. And it's hard to say exactly how many years away that is, but I think, you know, increasingly we are seeing much more personalised medicine. And I think, you know, I think the upside of that is that once people see the benefits that they will accrue by the use of technologies such as artificial intelligence, then I would hope that they would also feel more comfortable about sharing that information as well, which, you know, is obviously a key concern that people have about how their health data is being used. But I think when people see the benefits that accrue to them personally of being able to access the results of the application of artificial intelligence, I would hope that a lot of those barriers will be removed.
Perfect. Thank you very much. So if you can give a round of applause to Dave and Sue, thank you very much for starting us off there. I'll take the mic, please. Thank you. So I'll welcome our next panelists to come up and take a seat on the stage if you like. And while they're moving towards the chairs, I just do want to acknowledge our online listeners. So thank you for tuning in. Fortunately, you don't have to wear masks, so hopefully you're enjoying that comfort at home. And please do feel free to pop any questions you have in the chat. We will be taking questions from any online listeners. And also just in terms of the structure of this, so we will have a panel session now and we'll have Q&A at the end. So if you have any burning questions, just hold on to them and we will be coming around and answering any of your questions. But also as you all hopefully know, we have networking and some beautiful food and drinks after. So you should get a chance as well to talk to the panelists if you don't get your questions answered at the end. So I will take a seat myself, so I don't need to stand behind you all. It's probably a bit easier. And just introduce our fantastic panel that we're starting with today. So today on our panel, we have Dr. Megan McConnell. So Megan is a recent biomedical engineering PhD graduate. She's currently working as a data scientist with Datawi. And during her PhD candidature, she specialised on improving the reliability of various heart rate variability metrics and their subsequent use in predictive healthcare analytics. Within her role at Datawi, Meg is now looking into measures to both record and improve the general quality of the patient healthcare data collected, whilst continuing to expand her work in the area of predictive healthcare analytics. She's also been involved in the Young Women Leaders in AI and the Griffith Women in Engineering programs as a mentor. Then we also have next to me, Dr. Elliot Smith. So Elliot is the CEO and founder of Maxwell Plus. Elliot is one of the leading voices of artificial intelligence for healthcare in the world. After completing his PhD at the University of Queensland, Elliot founded Maxwell Plus after seeing huge issues with the rates of early and accurate detection. He has published numerous papers, turn my page, across the use of artificial intelligence in healthcare, and is a supervisor of a number of PhD students studying artificial intelligence applications to imaging of the brain and body. And we have Dr. Melissa Naidu. She is the Chief Medical Officer, Adjunct Associate Professor and Specialist Medical Administrator, MDMA National and University of Queensland. Dr. Melissa Naidu is a Specialist Medical Administrator, Advisor and Non-Executive Director with over 15 years experience in clinical medical leadership and executive roles across both the healthcare and insurance sectors. A cancer survivor and having been on both sides of medicine as a doctor and a patient, Melissa is passionate about person-centered care, health equity, digital health and innovation to enable better health outcomes. She's also the founder of Women in Medicine, and she's a vocal advocate for inclusion and is mentoring and training the next generation of diverse medical leaders through her college and university roles. And just checking, do we have our virtual panel member? We do have Talat. No worries, joining us virtually in one moment. We are all new to this combined event, so bear with us. So Talat, do we have you with us today?
Thank you.
Beautiful, there we go. Okay, hopefully we'll get your video up on the screen in a moment, but before we do that, I'll just introduce you. So Dr. Talat Oppal is the Director of Women's Health Road. Dr. Talat is the Director of Women's Health Road, an innovative multidisciplinary medical centre for women located at French Forest in Sydney, which is why she is coming in virtually. She's an obstetrician and gynecologist who also works both at the Northern Beaches and Hornsby Ku-ring-gai hospitals. She's also a clinical senior lecturer in obstetrics and gynecology at Northern Medical School, University of Sydney. So welcome to our amazing panel. And there we go, we can see you now. Hello.
Thank you so much for the opportunity.
So I'm going to start off asking each panelist to please tell us in one word what you think we need for effective implementation of AI. And I'll pass you the microphone as we do that.
So the one word that I had was village, as in it takes a village.
My one word is transparency.
And I'm a doctor by background, so I really struggled with one word, but I did narrow it down. Engagement.
Thank you. And Talat?
I would say embrace.
Embrace. Excellent. Okay. Well, interesting to hear that there are a variety of terms used there. So now I'd like to hear from all of you to elaborate on why you chose this word and what you really think is the key to us implementing AI in the healthcare system. And again, we'll start with you, Elliot.
Cool. Well, thank you. So the word I picked was village because it truly does take a village to get AI in healthcare to really work. In our business, we deal with patients, we deal with GPs, specialists, pathology providers, medical imaging providers, data scientists, engineers, the whole group of people that really need to come together to make this possible and to overcome some of the, I suppose, major flaws of what might be naive AI in healthcare, things like data bias, things like algorithms that don't really solve any clinical problems. So I think it really does take a lot of people to make all that happen.
So the word I settled on after picking many single words was transparency. And it encompasses more than just being transparent about what we're doing, but there's a lot of medical jargon that us data techies and your everyday person doesn't understand, but there's also a lot of technical jargon that doctors don't understand. And there's this miscommunication where I'm talking about something and I think, well, geez, you guys can understand what I'm saying, right? And not always. So I think we need to come together and really demystify this AI business. And it's not just throw some data at it and it tells you the answer. That's not really how it works. I mean, sure, that's the summary, but there's a lot of things that go into it. And if we're transparent about what we're using this data for, and it's for the benefit of public health and to find things earlier than what we would normally find them. And it, from my perspective, I don't want to replace doctors. I want to provide extra tools that doctors can use to help diagnose, to help treat. I want to get a whole bunch of AI that they can look at, and just like taking someone's heart rate, there'll be these new numbers that doctors get to see and take that into account when they're making the decision. So that was what I sort of thought from the data science side of things.
And I really like both those words, I think, village and transparency. I think transparency builds trust and it allows for engagement. And when I chose the word engagement, I really thought about sort of genuine and wide and diverse engagement. I think that co-creation and involvement are really early stage around, you know, what are the problems and the problem definition before coming to a solution that's looking for a problem is really, really important. But I think it's having all of those people involved in the village, as Elliot said, that's really important in moving this forward. And I think that was a really great reflection as well around how we all speak different languages. And so I think that the key to that engagement is actually starting to have a common language around all of this that allows everyone to engage with it.
And so
We can hear from you. That would be great.
thank you. So my word that I chose was embrace. And I think we are all actually really speaking the same language in different angles. And the future we know is virtual health, and the future is also AI. And the sooner that we, as clinicians especially, I think, begin to embrace this reality, the sooner I feel that we will make more and more steps in a positive direction for all the healthcare dollar is finite, as we know. If there's one thing that the pandemic has taught us is how limited our resources are and how quickly we can tip into situations where those resources are not necessarily enough for the needs that we have as a population. So I think it is time for us to doctors, and how do I put this tactfully, to not be dinosaurs, and for us to like has been mentioned by my amazing other panelists, actually collaborate in a way that we are seeking to do healthcare differently. And I think AI is very much part of that. And it's not about replacing doctors, but it's about actually using the time most efficiently. So I always think in a very clinical context, let's say I've quarantined 20 minutes for my consult. I'm like, well, how can I use 2 or 3 minutes for the mundane basic tasks and actually spend the rest of the time talking to women? So even though sometimes we are concerned that this is actually going to replace us, or it's going to, the reality is that most of the goals around artificial intelligence or general technology, digital technology, is actually to assist clinicians and for us to make more accurate decisions in a timely way and serve our patients in a very patient-centric way. Thank you.
Thank you for that answer. So yeah, very diverse answers. Now I did actually give them time. I was going to spring this question on them, but everyone obviously thought through that because I gave you time to prepare. And I'm interested that none of you said trust. Because I think that, you know, we can have a village ready to work on it. We can have people interested in engaging, but if we don't have trust, especially from the patient, we won't get uptake and implementation and use of AI in the healthcare system. So I'd like to hear, maybe starting with Melissa, coming from perhaps the doctor and the patient perspective, how can we build trust in AI so that we can use all of these different aspects to engage people in using AI and trusting it as part of their healthcare plan and part of their treatment plan?
Look, I think trust is something that is built over time. And I think trust is something that also is based on relationships. So I think it goes to some of the discussion we had before and, talking about things like transparency, open engagement, about involving people in the process around implementation of AI and understanding how that information is going to be used and how it benefits them. I think that's from a patient perspective as well as a clinical perspective. I spend a lot of time talking to doctors who are considering different, because I've taken quite a, non-traditional journey in my career. And so I get a lot of doctors talking to me about their careers as well. And there's a lot of dissatisfaction, I think. And I think that's because of a divergence from that patient care. And as Talat said, that ability to be able to concentrate on patient care and the reasons why we got into medicine or other clinical specialties is one of the benefits. And I think for clinicians to be able to see the benefits it brings them and their patients is a really big trust building exercise. I think if you manage to do that, then they can also help engage patients and build trust with them.
Meg, from a data perspective, how do you think we could make patients feel confident to consent to having AI being used as part of their healthcare treatment?
So there's sort of two factors here, and I suppose it depends on how you use their data. So one of the big parts of what we do at my company is data de-identification. So the patient healthcare signals that we're using to train our models don't relate back to you as an individual at all. And all of that private health information about you, well, that's all stripped away, and we're dealing with the signals to try and find trends that are generalized to different conditions, different medications and what have you. But I don't know who this ECG belongs to as a person. I just see an ECG. And I think that's a big part in trusting on that side of things, that when your data is used in a retrospective study, your name is never put to it. And that's a big part about that side of things. But there's also trusting the results of these machine learning algorithms. And I think that's where the doctors play a big role, because I trust what my doctor says. Okay, so if my doctor, he's a lot more experienced than me in many different medical fields, if he's looking at these algorithms and his intuition is, oh yeah, that's pretty similar to what the diagnosis that I would come up with based on this, that, the other, I'm going to have more trust as a patient. So I think the step in getting wider trust is us data scientists building that trust relationship with the doctors first, and having that communication passed down through the doctors to the patients, and having AI as a secondary tool to look at rather than a be-all end-all decision maker, is my perspective.
That speaks to a little bit it takes a village, because that's sort of getting trust on multiple levels of the healthcare system. And Elliot, so you work, I guess your company works directly with patients and in this case. So what's your experience in people's trust and engagement with the tools that your organization provides?
Yeah. So for some context, for those that don't know what we do, we provide a virtual care service for prostate cancer testing to help with early detection of prostate cancer. We have doctors that work for us that use the AI that we've developed to help assess the data of men across the country. I think it's been an interesting process for us. As a company, we first had to convince the clinicians, and that came very much from your traditional route of publication, peer review, large studies. And then I think this sort of speaks to the current nature of AI devices in healthcare, is that they are clinical decision support tools. There has not yet been, and perhaps never will be, or we can debate whether there should be, an AI tool that replaces a clinical decision made directly available to the doctor without clinical intervention. It's quite dangerous, but that aside, I think the benefit we have is that the patients trust the doctors, and the patients build a relationship with those doctors. And I think we can leverage the many decades, if not hundreds of years of trust that's been built within the medical fraternity to say, look, you need to place your trust in the doctor who's placing their trust in these tools, and knowing that all of these parties have sort of worked together within their expertise means that we don't have to educate every patient about AI, data bias, clinical use cases, how the product works, because they have that trusting relationship with their doctor.
That's very interesting perspective. And Talat, as a clinician, what would be your thoughts on patient engagement and trust of AI tools?
Yes, very good question. I think many times we actually underestimate our current patients. When I was setting up my practice, which is quite automated, I was told by a number of people who were mentoring me, or, I really looked up to amazing clinical gurus who then said, oh no, they'll never have time for this. So for example, we have a patient portal in which, if I just share a patient journey, we actually put images from their surgery into that. We put their operation reports, all their results go in, we give them homework to read up on before the next appointment, etc. And now we're looking at creating videos, and which is obviously slightly different to the core AI pathway, but I think all of these things are interlinked. And behind me, you'll see a number of screens. And for example, like a colposcopy, I would say to the women, oh, we've got a very integrated chair. I can actually show you the screen. Would you like to see your cervix? Would you like to see which part I actually want to biopsy? And I can explain better what is going on. You'd be surprised how many women say yes to that. And they say, we've never been asked. I'm sure the next level up, if I had capacity in that machine to actually highlight the most abnormal areas to support me in that decision, would actually be just as well embraced. So I think it is, the women need to be, or the patients need to be in the driving seats of these journeys. So like Steve Jobs said, basically we need the technology to, we need the consumer to lead the technology rather than to make the technology and then think, how do I fix this? So we really need to figure out what questions is it that we're trying to answer. And if the patients are in the driving seats of those questions, I feel that then the answers, they will see the benefit better for them. So I think that, like Melissa said, the engagement factor is very critical, but who is it that we're trying to serve needs to be first very clearly defined. Another example I was going to say, for example, in pregnancy, we're still using this across the country for every woman that falls pregnant. So this is almost like an Excel sheet of her pregnancy diary. And literally every time I, two-finger type or handwrite into this, I think, why are we doing this? Why isn't there a program that will just pick out the results, be able to tell us which results are normal, be able to help decision support better. So I think there's a huge need, but we're stuck in that chicken egg cycle that unless we have the confidence behind this, or we have the courage to innovate or to ask, I don't know that we will move forward as well as we hope we should. Thank you.
Thank you. And I think that's a good point you touched on at the end there, Talat, that, we often talk in these forums about the really cool side of AI for healthcare, and we can, predict cancer or detect cancer easier and all sorts of cool things on the clinical side. But there's also that patient flow and those sort of the mundane tasks that, we actually do engage AI, every day. It makes our lives easier. Predictive text, thank goodness we have that. Otherwise I would have a lot of spelling errors and things I do. And, all the different ways that AI can help us on that sort of mundane level and specific to the healthcare system. I do know in speaking to some clinicians that patient flow is something they see as an issue that prevents them from providing better care or more widespread care, because they might have issues with that because it's still very monotonous. So So
Yes,
lots of
I
different
100%,
we can use.
100% agree with you. So for example,
Sorry to let you just on mute, but we'll just love to hear your comments.
yeah, I was just saying that, for example, something as simple as speech recognition or being able to dictate has allowed us to send all our GP letters every single day. We say the sun cannot set on our practice without the GP specialist letter going back to them. And many of my colleagues are like, oh, I've got weekend, I have 40 letters, I have this, I have that. And I'm thinking, what? Why do you have that? But it is actually the automation and the AI and the digital technology that is enabling us to do that. Is not that we're any better or any and I think that's where the hearts and minds that we need to conquer is that they're very, very tangible managerial level benefits, not only clinician led benefits, but it actually does give you a better quality of life if you can get your same work done in a better way and in a more timely way.
Excellent, thank you. So now I'd like to open up to the, get that muted, thank you. Open up to the audience and see if there are any questions that anyone would like to ask our panel today on this topic. We also might have some online. No worries, thanks, SJ. Yeah.
Thanks. So my question relates to what are the top 3 use cases, I mean, up to 3, that you guys have seen where AI has brought significant value to improving service delivery in healthcare?
I mean, maybe I'll start just because I'm holding the microphone already. I would say, look, broadly speaking, the solutions that I've seen fall into sort of efficiency-based AI solutions. So we get a ton of X-rays and we need to get through them a little bit faster because we just cannot keep up with the workload. And there are a lot of companies out there that have shown great benefits in that range. So it's not about can we read them better, it's just let's do the same thing much faster because we cannot keep up with demand. And in emergency situations or high volume situations, that's very, very helpful. The second I would say is better clinical utility. So finding stuff earlier, finding stuff that otherwise got missed, giving things a second pair of eyes. Radiology is one space where there's been tons and tons of solutions, which are, I'd say maybe we're still too early to say whether any of them have really thrived, but they're starting to show promise. Come back to me in 5 years and I'll give you a definitive answer on that one. And then I think the third one that we've seen is in sort of the early patient triage space, which is working quite well. So an example of that would be a company called Babylon, which is quite big in the US and the UK. They're a smart chatbot, which you talk to it, you explain your symptoms, and particularly in the NHS where wait times and sort of the workload is quite high, its job is to say, should you go to your GP, and that might be in 3, 6, 12 weeks, or should you go to the emergency room because this can't wait, which kind of falls into the efficiency play, but is really more patient facing than some of the others which sit sort of with a clinician behind the scenes.
Yeah, you've summarized really well. One particular more specific use case that might be a good example is the Deadly Ears program. I'm not sure how many people would have heard of this, but basically there's an app for diagnosing, something, I'm not a doctor, something to do with the ear. And it's allowing a lot of the Aboriginal children out in remote regions, basically they get a camera and look in and take a photo, and they use that AI to tell whether that child needs to be seen or not. So there's all these remote regions where no specialist ear, nose and throat doctor is going to necessarily go out to or have the time to, but we're getting these photos and then that child can be referred to go see the specialist. It's a really cool program that's starting up, and it's got a very high accuracy from what I've heard. Not something I'm working on, but just a more specific example of how remote medicine is going to become better. Do you need to come and see someone or not? Deadly ears.
Look, probably not a lot to add to that. I think the patient-facing ones and consumer-facing, where we can do symptoms synthesis and advice and direction of care, obviously relieves strain on our health system as well. I think the other thing I could just think of there as well is around how we support other clinicians in remote areas or who don't have access to the same, I guess, specialist cells that we've got in metro areas as well. I think that's a really significant one where we can see AI actually delivering more equal care regardless of where you are.
And from my perspective, like choosing the best embryo to put in during IVF, for example, that is somewhere where AI is showing more and more value. Diagnostic imaging, again, ultrasound based, to be able to, again, for example, knowing the details there that would assist clinicians. And in cervical screening, so for that, from a pathological context, to be able to identify earlier the right women who need further investigations. So those are three clinical contexts in women's health. There's not a lot, but these are the three, I think, that are probably the best examples.
Great, thanks everyone. I hope that answered your question. There are a lot of examples there. Maybe we'll take, do we have any questions online? Just want to, yeah, SJ will be our translator. Thank you. Okay, so the first one is from Anton, and they ask, AI in healthcare offers huge opportunities, but right now most health data required for developing AI models is locked away behind the walls of data custodians in a wide variety of sites across Australia. To access this data is very slow and difficult, often impossible. Do you see this as a significant bottleneck to rolling out AI in health, and what work is being done to change it?
Briefly, yes, it is a huge bottleneck. I think so our company's been around for about 5 years. I would say that the first 3 years were really focused around gathering data. I think a big part of this is that there's really, I mean, everybody has a different opinion on who owns the data. At the end of the day, my belief is that data about you should probably own it. But despite the attempts of My Health Record and other initiatives, there really isn't a way that you as an individual can say, here is all of my data. I give it to you to do what you want to do with it. And there are initiatives in place, but I don't think we're quite there yet. So yes, big bottleneck.
Yeah, so that question actually lines up perfectly with my company. So the company that I'm working for is Tatawi, and this is probably the key business concern about what our company is about, unlocking that potential data by removing some of the risk factors, that de-identification that I was talking about earlier. But we are joining forces with Queensland Health and Queensland AI Hub as well, a few other things. But basically at the moment, the Gold Coast Uni Hospital, we have copies of the electronic medical record, and we're also beginning to stream high frequency data like patient ECG, their SpO2, and as time goes on, we'll be collecting more and more. But the idea behind that is to improve access to researchers. I mean, when I was doing my PhD, I requested access to some of the Gold Coast Uni Hospital's data basically day one, and got that access year 3.5 in. So only a few months before I submitted, and it wasn't any good to me by then because all my work had been done. We want to speed up that process at Tatawi, and by removing that private information that links, that personal information links, the patient name, any sort of revealing details, we hope to speed up the access to that data by removing a lot of those ethical hoops, and also doing a lot of data preparation. I'm not sure how many of you are familiar with the saying that 80% of machine learning is data prep. So if we as a company can prepare that data, then researchers can come in and know that they've got clean data, they've got patient healthcare outcomes, statistics, all of this information collected together. It's reliable, it's quality, and it's de-identified, and hopefully really speed up that process. We've got Gold Coast Hospital on board at the moment, and Townsville Hospital hoping to come on soon, and plenty of others in Queensland, and then maybe to New South Wales. We've got conversations going there too. So there, in the future, we will have lots of data, and it should be far more accessible.
I think it's a really difficult question because you've always got to balance, I think, governance and people, protection for people against, you know, the benefits and the good. But if I could give a practical example as a patient, I did gene testing on my cancer and had a unclassified variant, the BRCA gene, and so have always been treated as a BRCA, but that was really from lack of information about what that variant was, and it's really significantly contributed to the treatment that I've had over the years. About 8 years diagnosed now, so that's a significant time. We've come a long way in that. At some point in that, I had the option of providing my genetic data to a research group, and I got information that helped me make really different decisions to what I would have made otherwise. And so for me, that, you know, has huge day-to-day life impact. I know that's not how the information is meant to be used clinically, but it's an example of how these large data sets, which, you know, researchers and others can utilize for the good of people, that can actually impact the decisions that people make. Because I would make, you know, going back 8 years ago, without that information, would have made decisions that would have significantly impacted my quality of life.
Rat, did you have any comments on that question?
Look, I think that they've highlighted a lot of really, really good examples, and that's that I'm also a breast cancer survivor, and so I really can appreciate, Melissa, your comments in that space. Had a similar journey, not entirely the same, but I think there's a lot of potential there in malignancy journeys to create better futures by using these and creating the trust and building the trust in.
Up to time now, so I think we'll leave it there. But like I said, hopefully all the panelists will stick around after if you had any more burning questions you wanted to ask them. So if you could just give a round of applause and thank our amazing panel. Thank you. So we have a second panel this evening, a group of amazing speakers who I will call to come down the front now. And as you do, I will let you know a little bit more about each of them. So for our second discussion, we have Stephen Canaris, who is the Senior Director, Office of the CIO, Digital Health and Informatics for Metro South Health. This is Australia's first fully digital major health service. With approximately 15 years experience in the digital healthcare environment, Stephen currently provides leadership in digital health strategy, industry engagement and innovation and data analytics. We then have Dr. John Lambert. So he is the Chief Medical Officer of Harrison AI. Prior to joining Harrison AI, John was the inaugural Chief Clinical Information Officer of New South Wales Health. John is an experienced intensive care specialist working in the hospital and healthcare industry, from community practice to New South Wales government and international corporations. Also experienced in electronics, hardware design and software, with substantial experience in the digital health sector. So thank you, John, joining us online. Then we have Associate Professor Claire Sullivan. Claire leads the Queensland Digital Health Research Network at the Centre for Health Services Research, the University of Queensland. Claire graduated with honours in medicine from UQ as a research doctorate and has a research doctorate in medicine from the University of Leeds. She is a fellow of the Royal Australian College of Physicians, the Australian College of Health Informatics, and the Australasian Institute of Digital Health. Recently, she was appointed Associate Professor of Medicine in Clinical Informatics at UQ and is Adjunct Professor in the Faculty of Health at Queensland University of Technology. She has over $10 million in funding and has a large cohort of postdoctoral researchers and PhD students. She's widely published in clinical informatics and serves on several national advisory boards for digital health. We also have Brad Colbert. So Brad is the partner in analytics and cognitive at Deloitte Australia. Brad leverages data and analytics to drive and improve business outcomes. He's passionate about business-driven technology solutions that embed analytics to assist decision-making and innovation. Then we have Professor Ross Crawford. So Professor Ross Crawford is a chair in orthopedic research at QUT with a special interest in lower limb joint replacement. His principal interests are hip and knee replacement and knee arthroscopy. Professor Crawford is an internationally recognised expert in the field of hip and knee replacement surgery. He performs approximately 150 hip and 150 knee replacements per year. That's a lot, both in public and private practice. He also lectures and teaches surgical techniques both nationally and internationally. As well as running clinical practice, Professor Ross Crawford is the chair of orthopedic research and the professor of medical health robotics at QUT. He was an associate investigator in the Australian Centre for Robotic Vision. In this role, he supervises PhD students, postdoctoral researchers, and collaborates closely with experts in the field of robotics and mechatronics, mechanical and tissue engineering. He's published over 250 peer-reviewed articles, including work on health economics and big data. So an excellent panel for this next discussion as well. So the topic of this panel will be public perception and how do we build trust with adoption of AI. So I think what I'd like to start on is hearing from each of you in your experience, what is the current level of trust of clinician in AI tools for healthcare?
Thank you very much, Stephanie. So what is the current level of trust with clinicians in AI? And I have to say, I think it's unknown. As we've discussed today, there is only, I think, 29 AI algorithms approved by the FDA globally. So your average clinician is not yet interacting with AI. But I think we will see the usual spectrum that we see when we introduce any new technology. So 10% deniers, 10% early adopters, everyone else in the middle. And I don't think we should be afraid of that. I think we saw exactly the same thing when the thermometer was introduced in the Renaissance. So I wonder if we're overthinking all of this a little bit. It's just another tool, another thing that we can put into our kit bag and take into the clinic room. So I'm very optimistic about trust. I think that the best way to deal with this is to just use it as another tool in the kit bag. Remember, it's not all about doctors, although I'm an endocrinologist. It's our nursing colleagues, it's our allied health colleagues, it's our community workers, residential aged care, and it just becomes another tool that we use day to day. So I really think that demystifying it, taking some of the heat out of the conversation, making it another tool in our kit bag, the same way we do when we introduce any new technology, will be critical to a calm, measured and effective rollout.
Thank you. Look, I think trust is such an important topic to be talking about right now in the area of AI. And for me, the focus has been very much on the technology side of things in recent times. The explosion of data that we've had within our world and the huge volumes that we're now collecting, the progression of AI technologies and advanced analytics technologies and the focus of vendors in pushing forward in that space. And the paradigm shift that cloud compute has made available to us and the way that's completely changed the way that we can approach the area of AI within healthcare. But all of that has meant that the focus that we've had in recent years has been very much on technology. And I think the topic of trust is a really positive focus for us to be talking about. And that area of trust in AI, I think, starts with trust in the data that we're using in the application of AI. And that begins with having robust processes in how we're actually capturing and collecting data. We've done a lot of work in and around Queensland Health and HHSs in trying to leverage the huge volumes that are now being collected within the EMR rollout that has come about. And I think the opportunities that come from all the good work that's been done done in the past don't just stop at the digitisation of medical records. I think we've had some great wins to date on that basis, but the opportunity ahead of us is to be able to better leverage and harness that data. And, you know, for some time we focused on the topic of data governance in the world of data warehousing and analytics. And I think that topic and all the good things around stewardship, privacy, security, and data quality only extend into the world of AI, and we need to expand that concept of data governance to include AI governance and all the additional considerations in terms of how we're approaching the ethics side of AI, how we're putting some guide rails and frameworks in place in terms of how we are building AI models to augment human intelligence in clinicians rather than replace as an important thought process. And so I think that progression from data governance to AI governance and focusing on the trusted data is a key aspect to improving the trust for clinicians in AI.
Yeah, I think probably to echo and steal Claire's response, I would say it's probably unknown to answer the question simply. I think from a personal perspective, in terms of working within a health service and working at that coalface level with clinicians day to day, there is a level of skepticism out there. But that's not to say that there's not probably an equal amount of excitement at the possibility of application of AI into healthcare. I do think a lot of it's around there's a lot of really generic terms used when we talk about AI and machine learning, and it's sort of quite often kept at that really high level. And I think we need to be cognizant of the need to consider trust in all of this, but we really need to quite quickly jump down and distill it down to practical application of use cases. And I think that's what clinicians especially will connect with when we can demonstrate at a practical level how this will help them look after their patients day to day. That's when trust will start to diminish.
I take it slightly different tack. So we've kind of had 7 people answer the question on trust. I think there is genuine fear amongst the number of clinicians. Partly that's due to a lack of understanding, but partly because once you're a trained doctor and you subspecialize, that's the only skill you have. I'm a very good hip and knee surgeon, but I could not apply for any other job except being a hip and knee surgeon. And so if something comes out to take my job away, then I'm in a lot of trouble. And there's been a really good example recently where Google introduced an app that could diagnose skin lesions. And it was good enough that the literature that was published in Nature, which you probably all realize if you publish a paper in Nature, it's a pretty good paper. And it said this technology is as good at reading skin lesions as the best pathologists in the world and better than a general practitioner. Every young person I talk to says, I want this app. I don't want to have to, I can check my skin lesions more regularly. I can do things. The College of Dermatologists came out and said, this is a disaster. It's going to kill patients. It's really bad. We shouldn't be using technology such as this. And to me, that's not looking at, if that app now, every kid in Africa, every kid in India can have, any person can have that technology used to help diagnose their lesions. And we can pick up malignant lesions quicker. The patient's not going to necessarily want to go to a dermatologist and pay $200 every year to have their skin checked, but they'd very happily get their skin checked more regularly if it was easy. So the people who look at things and make diagnosis, I think, are a little bit anxious. I've got a friend who's the top liver pathologist in the world. He gets sent really complicated liver biopsies to diagnose, and he's kind of the ultimate authority on what it is. And I said, why don't you write an algorithm that can, so your brain will live on forever, and we can take your knowledge and use what you're doing to look at things. And he said, I don't want to be the one to take pathology out of medical profession and make it an app. But we're happy to have a full blood count run on a machine. We're happy to have all this other stuff done on machines. So I think some of there's almost trust that this is better than us. And so there's a little bit of fear in certain areas. I know it's not going to replace us, but it will replace some of us, and it will change, as we've heard earlier, a lot of what, how we can probably make the diagnosis in 2 minutes over using an algorithm and then spend more time with the patient. But yeah, so I think there's a fear that we trust it too much.
We'll hear from John, and then Claire has a comment on that as well. So,
yeah, hi. I hope you can hear me. Clearly, building trust takes time, and if it doesn't take time, the only way you really build it is by building on trusted relationships. And in a sense, I would say it's no different for AI than it is for any other medical therapy or device. Generally speaking, a new device or a new drug, we rely on the evidence first, and then our experience guides how well we trust that evidence in practice. And you've only got to look at, recent issues, AstraZeneca. Like when it first came out, all the evidence was great, and then it didn't take much of a challenge with a very rare side effect to actually undermine a huge amount of trust. So, these are not new issues, and I think that's one of the challenges we have. And I'd kind of echo what Claire said at the very beginning, that if you wanted to know clinicians' opinions about AI at the moment, it's unknown at present. Well, I would go further and say, what do clinicians know about AI? Not very much at present. So before they can trust it, they've got to understand it. And I think, part of the advantage of these sessions, and something I'd like to keep doing, and now that I am in the AI space, is to try and help clinicians come to a better understanding of what AI is all about. The other thing is, it's very new. I mean, we forget sometimes that an iPad is 11 years old, and AI, the ImageNet, a moment which sort of marks the commencement of modern day AI as we see it, was only in 2015. It's only 6 years old, which is a spot of time, compared to the history of most medical therapies. So, and on the other side of the coin, I would say, I've been involved in situations where we get to show clinicians a working AI, that's been designed to solve a real problem in a useful and usable way. And the speed at which they appreciate it, understand it, work out where it can help them, want to use it, reach out for it, and basically sort of almost are too trusting, almost in a childlike manner, is actually another dimension to the trust problem, because we want to make sure people put their trust in the right tools, but sometimes they can be so exciting and so wonderful that people just want to get into it straight away. So there is a challenge there, but it is more in that sense about the evidence behind it and how useful and usable is this, and does it actually solve a problem that I care about.
Thank you. Claire, you had some comments?
Yeah, I'm just trying to reassure Ross not to be afraid. And you can probably tell my dad is a history professor, but I'll go back to the thermometer example. So in the 1600s in St. Guy's and Thomas's Hospital, the doctors didn't want to introduce thermometers because they thought they would be replaced. So they actively banned thermometers because they were going to replace the doctors. And that's because doctoring at that time in history was literally putting your hand on somebody's head and saying, I've got a fever. What happened was that as the thermometers were introduced, the doctors learned new skills. They had more time because they weren't putting their hand on everyone's forehead and saying, you've got a temperature. They had time to go away and work with the apothecaries, to develop new drugs, to start to think about other ways of diagnosing illnesses. And so I think that we shouldn't be afraid of new technology, that it will replace some of our skills, and perhaps that's a good thing. And I suggest that the doctors who will not be replaced by AI, but doctors who don't use AI will be replaced by those who do. So I'm not afraid. I look at large amounts of blood glucose levels every Wednesday morning, work in the Royal Brisbane and Women's Hospital, a quaternary diabetes centre. And if somebody could possibly download my brain to adjust that glargine so that I don't have to make that decision, and instead I can check, is it actually appropriate for somebody who's 93 to have their glargine adjusted for perfect diabetic control. So I think what it does is it frees us up. It allows us to deliver new skills, and perhaps some things are better done by AI. So long as there's that clinician in the loop, I think it's wonderful. So a slightly different view, Ross.
Interesting. Yep.
I think I agree with you from the majority of people practicing with patient contact, but people aren't going to be reading x-rays in 10 years. They'll be read by AI. So radiologists are going to have to think of something else. We won't be doing pathology in 10 years. So pathologists have to think of something else. And there'll be a lot of dermatology and anyone who looks at something and says that's what that is in trouble. I completely concur with everything everyone else has said about this is going to just give us more time to actually think about things and do a better job. And maybe we'll choose medical students who are more empathetic and better communicators because they won't need to have big brains to make the diagnosis because you don't need to know that. It's all findable. But there are some subsets that I think are probably in a bit of trouble.
So those few comments then. Oh, sorry, John. By all means.
I was just going to thank you. Look, the other thing we're missing here is who's going to build these AI models. You know, we build them with doctors, and I think that's actually the best way to do it. And in fact, living with doctors as we're building these tools, I see their responses, and it's I think what might be underestimated slightly is the resilience and intelligence of doctors and their ability to work out new ways of working around these tools. I think you're also maybe being a bit optimistic about what we can actually do in 10 years in terms of the performance of AI solutions. There is, despite the jokes that we make about pathologists, dermatologists, radiologists, and orthopedic surgeons, they do actually get out of the operating theatre, the laboratory from time to time and actually talk to humans. And there's a lot of that. And many of the clinicians, I hope you don't mind, I'm just teasing, but I'm an intensivist, so I hope that allows me to say things. It does allow them to amplify the parts of their job that they often, it's been said before, but like we've had very strong feedback that people really look forward to being able to do the things that they actually think make a bigger difference, you know, attending multidisciplinary team meetings, consulting with colleagues and talking to them about the case rather than just sitting in a dark room reporting. So who knows where the actual answer will be. I think it's somewhere in the middle of the extremes we've heard today. But from the early experiences I've involved in, it's amazing how quickly clinicians, once they understand things a little bit better, take on a positive slant and work out ways of leveraging the opportunity.
And so on that, I was just going to ask, you know, obviously to some people it may sound like you're saying, okay, now clinicians need to learn all about AI and maybe understand how to build algorithms, or do they just need to understand how they work, or do they just need to get given this tool and sort of blindly use it? I'd like to hear your comments on how important is the depth of knowledge of AI for the clinician to engage. And do you think that transparency or explainability, I'm sure most people understand what I mean by that, is if an algorithm tells you this is, you know, the diagnosis, it also comes with an explanation of why it came to that conclusion. How important do you think that is for clinician trust and engagement and moving forward?
I don't think there's a single answer for that. And I'm not sure why we keep putting AI in its own special category. I know we're at the AI Hub, but I would counter with the same MRI scans, corticosteroid assays, psychometric testing. So clinicians are used to interpreting tests. They are used to taking results from things that they don't fully understand. And each clinician will have an individual view on how much they want to understand how the sodium analyzer works, how the psychometric testing is evidence-based or not, and a differing view on how much they want to understand about AI. So I think stop putting it in its own little basket. It is simply another tool or technology which is being adopted by clinicians. Each clinician will have a different view about what level of explainability they require. It needs to be explainable so that those super nerds who want to fully understand it can do so. But those who are trusted, busy, incredibly trusting of technology, which someone like me or Ross says is good to go, they won't care. They'll just look at the clinical decision support. And we see that through the entire spectrum of healthcare technologies and tools. So please don't think every clinician needs to know everything. There is a spectrum amongst the clinical community in terms of how much detail they want. We need to respect that and tailor the communications around AI to also respect that. So by suggesting that every clinician needs to understand AI, you're alienating a large group. You could ask, do they understand how an MRI scan is done or reported? Most of them know. So why is AI any different? And I think that's I guess, a leap we need to make in terms of putting AI into just the bag of tools, demystifying it a little bit. For those of you who are interested in a deep dive, we'll absolutely teach you, and it is transparent and it is explainable. But for those of you who like to look at the MRI scans, who like to just read the blood test, away you go.
It's a great response. And I guess building on Claire's response there, I guess the way that I think of this, and based on some of the discussion earlier, is that this is a clinical and analytical value chain. And what we may be doing is sort of moving some of the decision-making process up the value chain. I think clinicians are critical in the process and as important as they've ever been. You know, much like clinicians have been able to embrace many other technologies through the history of medicine over many years. You know, AI and the application of AI models is much the same. You know, the expertise that in terms of how the outcomes of those technologies are applied is absolutely is still needed. And I think honing in on some of the other things that we've seen in recent times is an evolution of the ways of working in the development of AI models, and where data scientists are moving to much more self-service ways of working and being able to leverage much larger data sets in more agile ways with perhaps less rigor around some of the early experimentation that's happening with some of the models that are being built. And I think as we move from an industry in a world where there's a lot of focus on experimentation and development of models in a very quick and an agile way, to the operationalization of some of those models, there is absolutely a need for some of the governance that I talked about earlier, but the explainability that you mentioned in the question, and clinicians are central to that process in taking some of those models from the laboratory, from the experimentation, and being able to operationalize those models and bringing them into the real world.
Yeah, so I thought I was really clear on what my response would be to this when Steph asked it, but just reflecting what Claire said there, I'm thinking on the fly now. Not to get caught up on terminology, but I think we need to distinguish between explainability of how AI works and perhaps even how an algorithm works, and then the difference between the need to understand that per se, as opposed to a clinician who has been presented a piece of insight from an algorithm, and the explainability as to how the algorithm reached that recommendation or piece of insight, to allow them to then distill what they do with that information. So I think a really important piece of that is the accuracy of an algorithm. So there's a big difference between an algorithm being 100% accurate and 60% accurate. So I think it's really important probably for a clinician to understand that first and foremost. But also when we start to, I think, delve down into the more personalized aspects of AI and its application in healthcare, it's important for a clinician to understand, specific to the person in front of them, why specifically that machine has recommended something, to then apply their own clinical judgment based on the specifics of what the machine thinks, versus what and who they're seeing in front of them. So yeah, at that really individual level, I think explainability is probably still very valid. But again, coming back to what Claire said, I think it's giving the information and then allowing the clinician to decide whether or not it's of value to them and whether they want to pay attention to it or not. And I think in all of this, that's the key of AI at the moment, is that it's a decision support tool. It's not something which is going to replace clinical decision making.
I usually try to disagree with everyone at these panels because it's more fun, but I can't here really. I have a number of PhD students who I've seen through to the completion of their PhD in the robotics and AI and machine learning sort of areas. And I've said to them, if I can understand what you've presented in your final seminar, then you've probably failed. And I've never understood anything that any of them said in their final seminar. I've set them a problem of we want to see if we can do autonomous knee arthroscopy, for example, or we want to see if we can design a concentric tube robot to go inside the head and do a biopsy and write the processes for that. And within weeks, it's out of my knowledge set and skill set, and I'm really interested in this, and I've got a reasonably understanding. So I think it'll be almost no clinician in the country will really care how the technology works. And Claire's point about an MRI, I use a surgical robot to assist me doing surgery. I know nothing about what's inside that box, and I don't need to. I just know that it works. And I think a lot of it will come with the algorithms. The best things will be they're published in Nature. And then once they're published, they'll have been read by people who actually understand it. And then we as clinicians can go, actually, the people who understand that stuff think that's a good algorithm, and then we can start to use it in clinical trials and practice. So I don't think we need to understand it pretty much at all. John, how many of your machines can you reverse engineer for us in ICU?
Well, you're asking the wrong person, because I started life as a hardware engineer and a computer programmer, so probably quite a lot. But no, you're absolutely right. Most people don't understand what's inside the black box, and they can function extremely well not knowing that. In fact, sadly, most people I know don't even read their manuals, even for something as complex as a ventilator. And it's amazing what you can do with a ventilator when you actually know how it works. But all jokes aside, look, how can I do anything but agree with what was said? I think there is a reasonably large body of clinicians who are out there crying out for more information about AI, though. So there is an unmet need in education. I agree with all the sentiments that how much you want to know and how much you need to know is very individual and depends on the nature of the problem. Just another topic that came up as well as this, how much do people need to understand, was this topic of explainability again. That can be a simple problem to solve. Like for some AI models, it's incredibly easy to demonstrate explainability in both the senses that were described earlier. But when it's an AI first model that's sensing things that humans cannot perceive, that's going to get quite tricky. So, I would go back to the last comment, which is about, it really, what matters is patient outcomes. And if you can demonstrate that using this tool creates a better patient outcome in a peer-reviewed, ideally randomized controlled trial in a journal like the Lancet Digital or the Lancet or Nature or Science or whatever, then, I think you've set the new innovative tool the same bar that you set every other therapy that we use in medicine, and that will win the day in the end. So, yeah, I'm sorry to not disagree more and create more consternation. But RTFM still rules, though.
That's fine. We'll see if we can find some questions for you guys to disagree with. So we will move on to questions from the audience now. Just raise your hand if you have any questions, and we'll also have a look at the online ones.
So we've talked a lot today about trust from patients and trust from doctors. I'm curious to know all your thoughts regarding the trust from government and regulatory bodies and how that would impact trust of clinicians and patients, and what you think the barriers are to removing that aspect of it.
I got the mic, so. John, do you want to start? You always go last. Do you want to go first?
I don't mind. I think half the panel have worked in government, so we all will have a view from there. Yeah, look, I think when it comes to making decisions about clinical tools, in every level of government, they tend to rely on the medical expertise of the relevant experts. And like, you hear it all the time on the news updates on COVID, etc. We've listened to the health expertise, maybe they have. But I think the more common problem I see is not so much trust, but how do you justify it? And generally that does come down to money. And it's, how do you convince the payer to pay for this new therapy is what I sense is the bigger issue. Yes, there's a bit of trust issue. And of course, because it's IT, there's this whole barricade of privacy and safety, security, cybersecurity, there's all so ignoring all the baseline stuff that any digital solution would need to get over to get implemented in a government environment. I suspect, government does a great job of creating committees and reference bodies to advise it. I think that obviously is going to happen for AI, just like any other therapy. It's no different. And I think then the tough bit sometimes is even at 20 cents, an X-ray, who's going to pay that money? Where are they going to see that saving? And one of the challenges I see is that AIs work at such a high level in the decision chain. The impact on an output that you can do is so abstracted that it can actually be really hard to measure that. So that's where I see the biggest barrier, is proving a connection between the cost and effort that is put in by the system to the benefit that is measured at the other end. And those research trials are hard. They take effort. The government has to be involved because they won't trust data that isn't from the government type environment. And I see that as a bigger value, a true measure of value to offset the cost against.
And I can get a slightly non-AI, but there's a surgical robot that we use that we now know 5 years into the journey that it pretty well halves the failure rate of the implants. There are quite a few systems in the private sector. There are 2 in the public sector in the whole of the country. And the governments are saying, why should we pay for this? And we should have 5 years ago when this technology was introduced, bought 10 of these robots in 10 centres and started studying it and seeing what the outcomes were and actually proving the value of the tech. And so I'm with John in that I think it's not their trust, it's the fact they don't want to pay for it. And they won't pay for it till you've done enough to show them that it works, and they won't help you show that it works by investing in the studies to see if it works. So I think that's the hindrance. It's not regulation or trust.
Yeah, I absolutely agree with investment is key, I think, in this space. I host or run a data analytics service for a health service, and we are at 150% capacity just supporting the day-to-day emergent needs of our organisation. And we've, I think, all just referenced throughout both panels the fact that healthcare is based on evidence-based medicine, which is born out of research. And when your whole analytics service is servicing day-to-day operational needs and doing no research, then it's very hard to progress things like AI and transform the organisation. So investment, I think, is key. I think the other thing is government is big and slow on most things. And I think we're just really big and slow in when it comes to working out how we appropriate data access and have a safe amount of governance wrapped around it, whilst also promoting research and innovation. And I know Claire, and hopefully a lot of that $10 million is Claire with a sledgehammer banging against a lot of the big parts of our organisation at the moment, trying to knock down some of those walls. So it is happening, but I think being government, we're just quite traditional and slow as well.
I think one of the other things is probably that can contribute to all the things that have been mentioned is improving literacy and awareness for data and AI in general, and helping regulatory bodies and government across the board feel more comfortable with firstly the art of the possible, but secondly the outcomes and the approach that's being taken to the delivery of AI solutions. And at Deloitte, one of the things that we've been doing is we recently launched the AI Institute, which is building out a AI fluency program for executives and senior leaders across organizations to help to improve awareness on the how AI can be approached in a very pragmatic and outcome focused way, but also with the appropriate governance and controls in place to ensure firstly success of the initiatives, but secondly that the trust can be central to the delivery process end to end.
So I think we need to pull ourselves together and develop an AI-ceutical industry. So we have a pharmaceutical industry where we have very rigorous phase 1, phase 2, phase 3 trials. We have a process for post-market monitoring that is incredibly robust, well-resourced, respected and trusted. At the moment, it seems to me that AI industry is largely entrepreneurial, which is fine because it's immature, but it needs to shift from an entrepreneurial model to an AI-ceutical model where there is an industry, regulation and a clear pathway to medical trust, implementation and lifecycle management.
Excellent, thank you. And I suppose just to add to your point, Claire, I think that's, you actually said yourself before, we need to stop putting AI in one single basket, because what you've just mentioned there, I think is a great idea, but that pertains to AI that will be used as a clinical tool but there are still also lots of other areas we can implement AI. Don't worry about those. So great point, but that would be a specific niche of when we can build more trust to not just say it's a clinical decision support tool, to say it's actually gone through a rigorous assessment and we can now use this and trust it to actually make the final decision. I think that's probably a long journey from what I've heard from TJ and other people, but I think it is the direction we're heading. We still have time for more questions, so go ahead.
Quick question, John. Can society really afford AI? And the reason I ask that is that obviously you say to people, we can extend your life with these better services, and only if you spend 1% more on health, but that means you've got to pay 10% more tax. How does AI address that? Because it is an additional cost, because all these services are not going to come cheap. So either you're going to remove human resources out of the cost model, because I don't think the budget's going to increase by health, because it's a finite money. And the question of investment is, which Paul do you pay to pay which Peter? So my question is, can we afford it? Or has it become a non-egalitarian issue where people with money will have access to all these algorithms that, you know, are going to do wonderful things for humanity?
Look, it's a great question. And I think, obviously, in all honesty, you can apply that question to every new therapy, like the robots that were discussed earlier, any new medication, etc. And one of the things to be aware of course, is that the envelope of money available to healthcare does go up every year, you know, especially in government-funded environments. So I think there is more envelope to play with, and that can fund it. I think on the whole, the AI, because the cost of computing is so low nowadays, that generally speaking, the benefit you may be able to generate through an AI model can be vastly superior on a cost per unit of benefit basis if you build good AI models. So we do have a problem at the moment that there's lots of great ideas out there and got lots of great mathematical models that deliver no value whatsoever, and so why should anybody pay for it? So yeah, you make a great point. There is a finite amount of resources. You should only invest in an AI model that actually delivers a benefit that is worthwhile. And yes, governments can sometimes choose to pay more money just to improve the quality of life. But generally speaking, we're looking about prolonging, you know, quality and functional life. And of course, you know, when you make somebody better, it's not just a feel-good event. You know, they become a productive member of society, deliver economic benefit. They keep, you know, families off public welfare, and you know, there's a whole. So we could look at the macro and microeconomic consequences of decision making. But I don't want to downplay your question, but I do feel that question can be leveled at any new therapy. AI is no different. We should subject AI to exactly the same rules. And if the value is there, then it'll be paid for. And sometimes that might take money from another less valuable therapy.
I'd actually argue we can't afford not to have it, because what it will bring with time are algorithms. And we know that, I'll give you an example. In New South Wales, they say if you come into the emergency department with chest pain, you have to do this, 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 and this. And it was the best people in the world had said, this is how you treat acute chest pain. And the mortality went through the floor because they took the clinical judgment out of it. And I'm not a fan of clinical judgment. And we don't all practice the same medicine, which means we're not all following the best algorithms. And so algorithms will come out of AI. And I'll be interested to see what Claire and John think about this, because I think it's going to make us harder to deviate from what is best clinical practice. We're going to have prescribing errors. We're not going to have people dying of blood clots who should have been managed because the algorithm would said that person needs to be on this. So I think it'll actually it'll save the healthcare system. To my mind, it'll save it a fortune. It's the question of whether, like the robot, whether they're prepared to invest up front for what will be the long-term savings. There might be a little bit of short-term pain, but I think there'll be massive savings to the healthcare system. Sorry?
It's got to be a return of investment. So it's got to drive efficiencies in order for, let's say, if you've got a finite amount of money, AI can bring efficiency. I'm sure it will in certain places, but I'm just saying that you're not going to double your budget to be able to get AI into the system, because you're not going to get the money.
A lot of these algorithms and the machine learning stuff, I don't think that's very expensive stuff to actually introduce. To me, that's going to make the biggest difference. Is that a doctor, I had a chronic cough. I went and saw a chest physician. He said, I'm not sure what's wrong with you. He pulled up the algorithm of the chest physicians of the world and said, this. And he went down the algorithm. He said, that's what's wrong with you. He is a trained chest physician. He used this algorithm that was written by the group of the best chest physicians. And so if we all have to follow those pathways, I think we'll have big savings. And it's probably true in ICU, John, that there'd be pathways you can't deviate from. And Claire, you'd probably have a similar thought. Not everyone's doing things as well as you are.
I mean,
Sure, yeah.
while the microphones. Oh, sorry.
Go for it, John.
I was just gonna say, well, the microphone's changing hands. Look, I mean, AI is just a more complex algorithm, really, than what we used to be able to program with basic logic. But one of the biggest differences, of course, is that it's much more personalized. So if you provide it with the appropriate inputs that are specific to that patient, you can actually deliver a much better protocolized care, which is more akin to what intelligence would determine. And so, yes, I mean, in a sense, you're describing why we want to use AI to make better predictions about what's going to happen to a patient and make the better recommendations in care. But one of the, I list about 7 different generic benefits of any AI solution. And one of them, which has been touched on in a few different ways today, is systemization. It'll create a systematic approach to things where currently there is no system. It's almost random what a lot of different clinicians will choose to do with a given patient.
I guess one point that I'd add is that affordability is a subject of value that's delivered and the approach that's taken, in my opinion. And, whilst absolutely there is significant investment required to go from that, world of experimentation and startup that we talked about earlier in the session to, truly pervasive operationalization of AI solutions. But if value is being delivered at each step along the way, it will build its own momentum and its own support to sort of increase the investments. And I think if a pragmatic approach is taken to the application of AI and the development of solutions, and that's a softly one step at a time approach is taken to show value at each step along the way, that momentum will self-sustain and it will be an incremental approach that builds over time.
Yeah, I think like Ross said, I don't think we can afford not to invest in this space. It's well documented, well known that the current or traditional system is not keeping up. We can't just keep building more hospitals to meet the demand. We need to think of alternate ways of delivering care. So yeah, it's an imperative, I think. And I think if we purely use investment and money as the reason we don't do this, then someone else is going to do it. We've seen other industries already revolutionized. Just look at what Uber has done to the taxi industry. I actually attended a conference a year or so ago with a presentation from one of the co-founders of Netflix, and he spoke about how they'd got Netflix to a certain degree, and there was clearly the opportunity there, and they met with Blockbuster and said, we've got this great company up and running. It's still early, but it's looking really promising. We want to sell it. I think it was for $40 million at the time. And he said they got laughed out of the building, literally laughed out of the building. And he went on to, well, we all know what happened with Netflix. I think he sold out at the time for $400 million in terms of his partnership. But yeah, we've seen other industries where people have had their heads in the sand, and whether it's because of money or because it's a very different proposition to how things have been done traditionally, they've been left behind. So I don't think we can afford to do that now and either.
Great question. So when you look at the pharmaceutical industry, and I guess I'm going back to my idea of the AI-ceutical industry, they have very sophisticated modelling in terms of the cost benefit of each medication that they put through. So I know, for example, that one of the insulins I use will save $70 per year per person if we have a certain number in Metro North that transcends to a particular cost. The pharmaceutical industry will tell you number needed to treat, how many people you need to treat with a particular medication to save a life or prevent a fracture. That type of thinking that the pharmaceutical industry has truly pioneered needs to urgently be applied to AI, because it then gives a cost model that the funders understand. They don't want an entrepreneur in the flashy show. They want the same type of costing models that they use to implement new costs, that they use to introduce or change the way that they work, is exactly as you've described. So we need to shift away from trying to be, innovative, and instead set ourselves up as a respected and rigorous way to show not only clinical benefit, but economic benefit. And I think learn some of those lessons that the pharmaceutical industry has developed beautifully in terms of marketing their products. Sanofi, Pfizer. The way that they market and can talk to the number needed to treat, the costs that they save is phenomenal. And that type of thinking needs to come into digital health, in my view.
Excellent.
I agree with that. And look, just to speak, sorry, I was just going to say, I totally support what Claire's saying, as I have all night by the looks of it. The other thing I would point out, I mean, Claire mentioned earlier the number of AI models that have received FDA approval. Now, even if we add CE mark and TGA approval to that, it's still not many. The number that are actually in use, in live clinical use today, is very, very small. The number of research articles that have proven an economic benefit, or even a clinical benefit, come to think of it, I think the number is still zero. So, you know, this is all hypothetical, what we're talking about, just to throw the cat among the pigeons. I mean, we wouldn't be in this business if we didn't think we were going to make a positive difference. But right at the moment, it hasn't been proven. But, you know, but I totally support Claire's idea. There are pros and cons in following this pharmaceutical company model, and it's very interesting looking at where they got the money to do what they did and how we can mirror that. Like we basically are funded by venture capitalists, which is a new source of money, but there's no reason why we couldn't use that money to set up a model like Claire's suggesting. And I have to say, I think that's what we're trying to do in the company I work for.
Fantastic, thank you. I believe we have one more question from the audience and then we'll have to wrap up. So yeah, go ahead.
Yeah, thank you for the talk. My question is more in regards to how much actually needs to be understood about AI in the medical clinical community. I guess the answer I got from the panel is not much, but I feel there is you're combining data analytics, machine learning, and then maybe even reinforcement learning, which comes from very deterministic results to very, let's say, non-deterministic policies that can improve health and help, but they won't give you 100% accurate results. And my question is more in regards to when you come to investment, you need to know where you're investing your money, right? What kind of application. And if you don't fully understand, or not fully, but at least to a certain level, understand the difference between what it's called AI through deep neural networks and what it's called AI for just using computer to crunch big data, does that still work well for business models and for medical purpose? Or there is a requirement to understand just a little bit better the difference between what it is traditional data analytics and what is actual AI to apply that in a better way?
I think in answering that question, I think it's probably in terms of where the investment is needed and how much clinicians need to be involved in the process. I think it's about the smart investment of resources, and perhaps ultimately when we look at the end state of mature AI products and solutions, that clinicians don't need to be fully invested and aware of the inner workings of the models that we use to create that product, but based on where we're at today, there is a lot of investment that's needed in terms of the further progression of some of those solutions. And so in focusing the investments in those areas, I think it's about working smarter about how we're approaching the delivery of some of these solutions. And taking, for example, Queensland Health as an example, there's a lot of work happening in this area across HHSs and essentially within Queensland Health itself. And I think there's a real opportunity to pull some of the thinking that's happening across the spectrum there and realise economies of scale and the centralisation of value. And I know there is some good work in that area already, but I think it's about working smarter about how we sort of pool resources and use resources to have the most effective use of what's available.
I think it simply just comes down to not getting caught up on sorry, to answer your question, I don't think, and we've heard it, I think probably from Claire and Ross already today, correct me if I'm wrong, guys, that there's not a big requirement to understand the ins and outs of what you're being asked to invest in. It really just comes down to the outcome that will be achieved from that piece of technology. Claire gave a great example from an endocrinology perspective, where she broke it down to an actual financial outcome in terms of using that particular drug, whether it's financial or from a health outcome perspective. I think that's really what, and I'll hand off to Ross and Claire because they are clinicians, but I think ultimately that's what, at least at a health service level, we look for is what outcome will be achieved, not understanding the technical ins and outs of how that would be produced.
Yeah, we need to understand what it does, not how it does it. Put simply, we don't need to know the back end of an MRI. You need to tell me what your tech can do, a little bit about how it could be implemented, how it might work with systems, but I don't need to understand how you use machine learning to create that algorithm, which data sets you investigated and how you investigated them. And, I just need to know that someone who understands that.
Great question. And I think it's a sign of our maturity now that we can shift away from talking to the models and how they're built to what they do. So I'd like to not talk about the model necessarily. I can if we have to, but what will actually cause transformation in healthcare is focusing on the outcomes as I've described. So it's time to shift away from, and I know it's exciting to the technical people, but the healthcare providers themselves couldn't care less and they'll zone out. So instead, follow that model. Understand what the outcomes are. What is the economic benefit? And then if somebody on the team wants to go through Shapley scores, do it. Yep.
Perfect. And John?
Oh, totally here with what Claire's saying. I mean, it's the clinical evidence, the outcome benefit, the usability, the usage metrics. That's what defines success. It doesn't, in a sense, if it works, does it matter what type of model it is underneath it? That's, I really do agree, but I do feel that there's still value at this early stage with such an innovative and new age sort of scary thing. We need to allow people to become more informed if they wish to. Just like the early days of the CT, people were getting inside the CT scanners and working out how the hell they worked. We're at that age. It's it's the Wild West still, unfortunately. So, whilst I totally agree, we should talk to clinicians using clinical language. There is still a cohort that would like to understand a little bit more about AI to take the mystery away, and I feel that those working in the industry are the only people equipped to solve that.
Excellent, thank you. So we have run out of time there, so apologies to anyone's questions who didn't get answered, but I think if we can just give a round of applause for our amazing panelists in the second panel. Thank you very much. So that concludes our forum for today. I hope you did all get some interesting insights from our panelists. And just to summarize, I think, the theme of this forum was the impact of AI in the healthcare sector, but I think we all can agree that it will have a big impact. But how do we get there to that impact? There seem to be, from what our panelists have said, many layers to this. Trust, there needs to be an investment made up front, and we know that there will be a great impact in the end, but we need to navigate through some of the current barriers that we have into implementing AI in the healthcare sector. But I think it's really exciting, and I think the fact that all of you are here engaging in these kinds of forums is really promising. So really glad to see so many faces and so many people in the healthcare system who are keen to learn about this area. I'll finish on a quote actually from Eric Topol, who some of you may know. He's an American physician and he engages a lot in AI research for healthcare. And he wrote a book on this topic. I'm not sponsored to say this, but it's just got some interesting insights in that book. And if we zoom out a little bit to think about why are we looking at implementing AI in healthcare, he says, the greatest opportunity offered by AI is not reducing errors or workloads or even curing cancer. It's the opportunity to restore the precious and time-honoured connection and trust between patients and doctors. So I think that's a really beautiful summary of the big picture here. So thank you. That's the end of our content. I do need to say a huge thank you to our sponsors. These events do cost money, and we had support from Deloitte and AWS. So Brad from Deloitte is here, and also Sean Ryder in the audience. So if you wanted to speak to either of those, they should be around hopefully for a little bit after. Thank you very much for that. Thank you for the team at BCS helping us organise this. It's been many months and a couple of date changes due to COVID, which everyone was very flexible about supporting us with, and the amazing team at the AI Hub for supporting this. And I think especially to our AV support today, it's not easy running hybrid events, but you got there in the end. So we appreciate everyone's patience with that, but we appreciate Ben, you working hard behind the scenes, sweating to get that working. So yeah, fantastic. There will be a survey that we'll be sending out to everyone, voluntary if you want to answer it. But what we really want to do is make sure that we continue this series of events. We will be running a few more events along this topic, and we want to really provide you with topics that you want to hear about. So by filling out that survey, you're actually helping us create events that are, really speak to the topics you want to hear and help us pick speakers for you that you'll really be able to engage with. And also in saying that, if you want to learn more about AI or engage more in these events, do check out the AI Hub website. We now have memberships and all sorts of different ways you can engage, so you can keep up to date on the fantastic events that the team is putting together very regularly. So on that note, you can probably smell the beautiful food that is cooking, and I can see many drinks poured ready for you all. So please stick around for some networking. Do remember we are supposed to be sitting down if we're eating and having our masks off, so we'll put out some chairs to facilitate that. But by all means, help yourself, and thank you very much. Hope you have a good rest of your evening.